It's such a pleasure to be joining this auspicious panel today to focus in a little more on assessing functional outcomes after transplant. And I have the good fortune of having observed with you the morning sessions that really provide a framework for what we'll discuss this afternoon and go into a little more depth on. And now everything's working except, there we go. So as you heard this morning, many areas of organ function are impacted by transplant long-term, as well as the increased risk for subsequent malignancies, sexuality and reproduction effects, which we didn't talk a lot about. Today, I'm going to be able to focus on what you see here in red, the physical and psychosocial functioning. And then I believe my colleague, Dr. Arnold, will be addressing some more of the social determinants and financial impacts of transplant. So when we look at what is impaired in long-term functional outcomes, in a scoping review that Dr. Bevans and I conducted with Dr. Al-Jawari and others, we determined that long-term physical function is impaired in 35% of our transplant survivors. With physical inactivity, and I'll really draw your attention to this because we come back to it later on, the physical inactivity rate in our survivors is extremely high, even if they're participating in physical activity on a regular basis for, say, half an hour a week. The vast majority are still otherwise in their lives highly inactive. We see sleep disruptions, emotional distress, and the other issues you see here with no return to work in at least 40%. But it is notable, as somebody pointed out this morning, that we also see very high rates of positive change, resilience, personal growth in our survivors, and even in caregivers where 76% endorse positive effects of going through this transplant process. Now, as we've heard, these are all averages, but when we look at these lives of all these transplant survivors that you see here, we would never guess that their goals, that their personal issues, and the pace of their recovery would be matched because their intentions are so diverse. And so we really need to think not only of averages, but also of individuals. So looking then at what is impacting disability and the pace of recovery, we saw that return to work takes up to 3 years, that physical recovery takes about a year to get back. And here I'll really reference to where people were pre-transplant, which is not where they necessarily want to be in their lives. So even at 10 years, when we followed people longitudinally, we saw that the long-term survivors were lower than controls. Similarly, in cognitive function, this recovery can take 2 to 5 years. And what's important here is that real-world function in, for instance, work may be very difficult to measure with our standard neuropsychological testing batteries. So that what people tell us, they get much more disrupted in their function when they're interrupted, that it's much more difficult to multitask. Finally, emotional recovery takes at least 2 years. And at 10 years, again, we see poorer mental health on average and greater use of psychiatric meds in patients than we do in non-cancer controls. Now, I won't have a chance to talk more about social network or social support, but I want to point out that that's going to be very relevant to someone's recovery and capabilities in the workforce, because we know, and you would know from your own lives, that if someone's there to do your grocery shopping, cooking, help you get to places you need to be in terms of transportation, your life is going to be a lot easier and you can focus more on work. So we don't want to forget that element as well. So when we think of where we look for information, we have essentially 3 strong sources of information and a fourth, the medical record. So you've heard some about patient-reported outcomes, or PROs. Also, I'll mention physical performance tests, lab-based tests and exams that we all expect to see. Oftentimes, though, when we talk about recovery and disability, we focus on medical records. So I just want to point out that we have to think about who's entering the information and what is their focus and priority. So we wouldn't expect an oncologist focused on treating disease and recurrence to necessarily be focused on how is someone's physical capability or ability to work. So we really do want to look beyond this at these widely used, reliable, validated, patient-reported outcomes and other sources of information. So our online assessments, what is really invaluable to our current state of opportunity to evaluate long-term function, is that we see now that online we can complete these PROs successfully by over 90% of our transplant survivors. So to our great fortune, internet access is widely available and used, even if it's on a smartphone. So we know these can be done. And we also know that we have very valid, reliable measures. There are two I'll focus on that you've already seen data from that are most commonly used that are brief. And one is the PROMIS system developed through NIH, which assesses all types of physical and mental function, but the brief measure has a global physical and mental function, as does the SF-12. And then we have longer measures that we can use. And you see some examples here where they may range from anywhere to 20 to 40 different items to go into more details on function and specific symptoms after transplant. When we get to the psychological mental health elements, we have, again, very brief but highly standardized and valuable measures. So I'll point out the Patient Health Questionnaire System, the PHQ, which is both the PHQ-9 for depression and the GAD-7 for generalized anxiety, are especially useful because they are not only designed to evaluate the diagnostic criteria in DSM-5, the Psychiatric Diagnostic Manual, but they also have cut points that can be used to determine who has mild, moderate, or severe symptoms. Now, for post-traumatic stress disorder, we don't have a good PROMIS or we don't have a good PHQ system measure, but the VA has developed an extremely strong measure, the PCL-5, which again maps to diagnostic criteria, and a brief 5-item screener that is again reliable. So we have good ways to measure this. Now, these are all standard clinical criteria across any diagnosis, any person, even without a medical diagnosis. But in cancer, and especially in transplant, we very often talk about distress. And distress is a construct that really expands beyond just depression, anxiety, or trauma. And it's really this sense that while on the surface, everything may look good, everyone's going about their life, but in a survivor, there's often this sense of potential uncertainty and potential collapse. And this is that distress criteria that we think of as uncertainty, fear of recurrence, loss of control. So we really want to be able to capture that element as well. We have some measures, as you see them here, the distress thermometer, brief symptom inventory, and the one I'll focus on is the CTXD. And in full disclosure, I want to say I did develop this measure with colleagues. So it was developed, though, in transplant. It has 6 subscales. So it is providing us an assessment of these qualities of distress. And the 6 subscales are those that you see here. These are the ones that people tell us are most impaired in their quality of life, both during and after treatment. And there's nothing surprising in them, really. Uncertainty, burden of their health problems, family strain, changes in appearance, etc., and certainly finances. So when we capture this, we're actually able to also capture those people who are depressed or anxious and those people with trauma, but we also capture those people who may not have clinical syndromes of those disorders, but are still distressed in a way that impacts their life. Now, in assessing work and disability, it was so interesting to me in preparing because we've done work in return to work, but I found that there were no studies that I at least found that used the 3 most commonly used measures of work performance. So I'm looking forward to seeing in the future use of these measures with our transplant survivors, so we get a better pulse on the extent to which absenteeism, presenteeism, being at work but not productive, as I'm sure you know. And then the other elements of work dysfunction are impacting their lives. When we get to performance measures, we have numerous functional measures, the 6-minute walk, maximum strength, and of course the treadmill is the gold standard where we can assess aerobic capacity. And then we have patient-reported outcomes, and increasingly now we have the advantage of real-time measures. So it's great to get what people say they do on average, but being able to use an accelerometer or other wearable device to understand what their real activity is, and not just how much they're exercising, but are they moving during the day? This is a tremendous advantage. So moving on, you heard more about accelerated aging and frailty. And just to remind you, these are the 5 symptoms that constitute frailty. Now, in my preferences, I'd like to see this assessed by physical performance testing. But because our patients are often distant from us, we often depend on reliable but self-report measures using patient-reported outcomes. In these, studies indicate, as you heard from Dr. Lee earlier, that 8.4% of young adults at a median of 8 years are reaching the category of 3 impairments out of these 5 and considered frail, versus 7% in pediatric 10-year survivors. So not an insignificant number of people. After transplant, we do know that frailty is associated with more chronic diseases and increased mortality risk. So it's important for us to be monitoring. For cognitive function, the most common screening tool is the MOPA. It has about 30 items. It's not very sensitive to the cognitive dysfunction that our patients report to us because their dysfunction is so often in the range we would consider mild, still disruptive, but still in the mild range. So it does have some sensitivity issues, but it can be used as a screening tool. We do like to wait till at least 1 year after recovery from transplant to do a more extended neuropsychological testing, because we know that the majority of people will be still recovering in that window of time. So we don't have a stable evaluation until we hit that 1 year or sometimes even 2 year time point. The other caution to note is that PROs can be more strongly associated with our mental health measures rather than the neuropsychological testing. So we may start with, but we don't end with, the patient's self-report of their neuropsychological testing results. When we turn to sleep, the Pittsburgh Sleep Quality Index is the most commonly used. But wearables are expanding our access to understanding real time, again, how people's sleep is occurring. But the gold standard remains a sleep study test. Now on to lab or exams. Here's another important element for us, and what's again really expanded by the use of technology now is that a lot of these tests are available. Even blood tests can be done at home, and we have numerous portable devices for assessing people's function, such as spirometry, pulmonary function, and blood pressure, etc., glucose monitoring. And then the DEXA scan for bone density, body composition, sometimes people are using a CT scan, are also essential tools for us in understanding body composition changes. And I'd like to go just briefly into that a bit more. When we look at aggregating these test results, we can often get a much better indication of risk for mortality, physical disability, or even predicting cardiovascular events than we can when we look at any single measure alone. And you saw that with frailty, but I'll also point out that metabolic syndrome is elevated in our survivors. So 38% of 2-year plus survivors had elevations that constitute metabolic syndrome, elevated blood pressure, glucose, triglycerides, cholesterol, and the central adiposity or abdominal adiposity. And this predicts cardiovascular events as well as survival. Another syndrome that we're seeing, and that's closely, that is a piece of what we think of in frailty, but is far more common than the overall frailty index, or phenotype is this sarcopenic obesity. And that is low muscle mass combined with large fat mass. So in this, we see that after transplant, obesity based on fat mass is common in 62% of the patients we assessed. And these patients, by and large, only 16% of them were obese in body mass index. So it's a very discrepant difference between the fat mass used assessed by DEXA and by body mass index. So we saw pre-sarcopenia in 34 to 55% of people receiving transplant, and this increases at 2.5 years to 42 to 76%. So a huge population, which predicts then survival. So in functional outcomes, in summary then, we see that measured by PRO scans or exams, these tests are closely tied to comorbidity of frailty, metabolic syndrome, and sarcopenic obesity. We also want to remember that these outcomes are all highly interrelated. So mental, whether it's emotional, cognitive, and physical function, are often associated, as you would expect. The worse someone feels physically, the worse they're going to feel mentally. And these outcomes clearly impact work performance and disability. What we see in our research is that the more flexibility and accommodation we can get in the work environment, the more we can improve work success. And we want to remember that these outcomes predict later disability and mortality. So they really warrant our attention, our routine assessment, and especially our interventions. With that, thank you very much. I will pass it back to you.